Primary progressive aphasia, a neurologic disorder in which language slowly becomes impaired, has received recent media attention.
And on this week's Health Talk, we will be joined by a speech pathologist who will discuss the challenges faced by patients with this disease, as well as the help that's available.
Stay tuned. Health Talk is coming up next.
Hi, I'm Dr. Eric Mazer.
And I'm Dr. Andrea Peterson. Today we're going to discuss primary progressive aphasia. We're joined by Marta Korytkowska. She's a speech pathologist with Norwalk Hospital.
Marta, welcome to Health Talk. It's great to have you. First time.
Yes.
Welcome.
Thank you so much for having me.
Well, we're going to talk about something that I suspect virtually none of our viewers have heard about, primary progressive aphasia. I had mentioned to you before the show, I hadn't even heard of it until recently when I crossed an article. Tell us first of all what aphasia is, and then the specific entity of primary progressive aphasia.
Sure. So aphasia, a lot of people associate aphasia with stroke. A lesion, so a stroke to the left side of the brain, causes aphasia, which is a difficulty with language or finding the right words. People might have speech that's not very fluent, pause a lot, have a lot of hesitations. And primary progressive...
And some people
Sure.
I know can understand or can speak, but they don't speak, they speak gibberish because they have trouble even understanding what you're saying.
Of course. So the other side of the expressive portion is the understanding portion, the comprehension.
Right. So aphasia is kind of an umbrella term, if you will, for some troubles with language, and then there are different kinds of aphasias.
Yes.
Right. And before we leave this, I did want to say, it's amazing to me that how localized within the brain speech is. It's not general, it's very specific. And you may want to say just a couple of words about that.
Yeah, so speech is mostly thought of, there's of course some differences among individuals, to be localized in the left side of the brain. The temporal lobe has a lot of implications for the comprehension of it, and it's near your ear, so that kind of makes sense. That's how we remember or teach students. And then there's the expressive portion, which is also in the left side of the brain, and we associate that with Broca's region in the brain.
And so maybe just again, because we kind of went through it quickly a little bit, you talked about the words expressive aphasia and receptive aphasia, and that's important, and maybe you could define those one more time.
So the expressive portion is being able to get your thoughts across, being able to find the right word, calling this a mug, for example, or a table versus a bottle and a chair, things that might be similar or related, or being able to get the words out without hesitating, without skipping the ed of a word or the. And then the receptive component is understanding information as it's being sent at you. So word order matters. You know, the lion was chased by the tiger was chased by the lion. Word order might matter for somebody with a receptive aphasia because they're not getting some of the words in between.
It's really interesting, the idea that, again, as I went to medical school and learned this, it's really interesting that it's not that they can't hear the words. Right. They have trouble taking the sounds, this is on a receptive base, and then taking those sounds and turning them into understandable language. By the same token, people with expressive aphasia don't have trouble making sounds, they have trouble, again, pulling up the word that represents the idea.
Right. And with some variations of aphasia, you might also have difficulty with pulling the right sound for the right word. So that's why we have somebody, instead of saying cat, may say dat, but they mean cat.
Yeah, and before we get on to primary progressive aphasia, I've seen a lot of older people with dementia, and word finding and seems to be very common in the early to middle phases of that dementia. You know, as you said, calling a cat a dog. You know,
right.
Although the sense of what it is similar, the word can be wrong. Can you say a few words about that? And do we understand that process? It's a really amazing process that's going on.
The language process is complicated and amazing and continuously evolving. So there's things that we know now about the brain, about how localized some of these areas are that we didn't know before. But when it comes to somebody who has dementia or just in the aging process, we forget the names for things. That's a part of the normal aging process, especially what we call low frequency words. So words like trellis. You don't see trellis every day. Unlike a cherry, that's something that's a high frequency word in our language. So it's common that we have more difficulty as we age with words that are low frequency and proper nouns. So the names for people or places, those are sort of the first to go in the aging process. But we find it eventually.
And by the way, what was trellis? No, just teasing.
So we talked about aphasias, and I think most of our viewers understand progressive, so something that's going on. What is a primary progressive aphasia as opposed to, say, with a secondary to a stroke?
Yeah, so primary progressive aphasia is actually a little bit of a misnomer because we associate with an aphasia like we have from stroke. And this is true, it is an aphasia, but it's actually a dementia, which is the progressive component of it. The primary word talks about the diagnoses of the symptoms. So the primary symptoms are language symptoms. It's a difficulty with language that interferes with everyday activities as opposed to a cognitive issue with attention or memory that would interfere with these activities.
So this is a localized disorder that we believe starts right in the brain in the language center and develops there. And it's not due to a secondary, it's not secondary to cause like a stroke or an embolism or something like that. It's primarily wrong with the brain. Do these folks have associated cognitive issues, dementia, the way we typically think of dementia in terms of memory and other things?
No, so not initially. Initially, the disease presents only in language impairments, word finding impairments, difficulty in understanding the information, especially if it's more complex or sentence with a lot of double negatives, embedded clauses, and so forth. And then it progresses to cognitive issues, but much later down the line. And people with primary progressive aphasia are often misdiagnosed with an Alzheimer's dementia.
And tell us a little bit about that. Why is it tricky sometimes to tell the difference between a primary language problem and a primary memory problem?
Well, a lot of the tests that we use for dementia or memory or Alzheimer's are all language-based. We use language in everything that we do. And if you can't tell somebody what you remember or what you're attending to, you're likely to get those things wrong. On tests of memory that use non-linguistic measures, like visual spatial sort of tasks where you have to put things in order or recalling a number sequence, people with primary progressive aphasia excel because this isn't what's getting in the way, it's the language issue.
That's really interesting. And I think one of the common tests you do for dementia, one of the really simple ones, is you tell somebody 3 things and you ask them to repeat those back to you in a few minutes. And of course, if you have, I've never thought of it that way, but if you have aphasia, you may actually remember those things but not be able to articulate them.
Right, or say them backwards or not be able to produce the right sounds for them. Another area is name these 3 animals ranging from high and low frequency, and you're not going to be able to do that because you don't have the words for them, not because you don't know what they are.
A platypus is going to be more trouble than a lion.
Agreed.
And fascinatingly, there actually are different types of even primary progressive aphasia, aren't there?
Yes. So there's 3 main types with the overarching explanation of they all have a difficulty with language. There's the non-fluent variant, which is exactly what it sounds like. Speech is halting. It presents with apraxia, so it's effortful, halting, groping speech, frequent hesitations. And then it's agrammatic, so it's missing some of those grammars. So somebody might say, instead of the boy walked to the store, they might say, boy walks store. They're missing the things that sort of in the middle in that sentence. Another variant is the semantic variant, and that's loss of semantic information. So these people will first have difficulty with naming an item, like for example, what is this, a chair? That will be difficult for them. But also point to the chair. They might point to the table versus the chair because they have impaired single item comprehension as well. And this variant of primary progressive aphasia actually progresses to difficulty with object knowledge. So somebody might take scissors and hold them the wrong way.
So not knowing
how to use the object. And again, that's...
So they know some people with aphasia will know what to do with the scissors or what to do with a comb, but they won't be able to name it.
Right.
This is different.
And the semantic variant, as it moves on, it has more of these issues. And then the third variant is the logopenic variant, which is the difficulty with finding the right words. And often, instead of saying having phonological distortion, so saying the wrong sound in place of a right sound versus the wrong word altogether.
Oh, that's interesting. So that's different than someone saying cat instead of dog. It would be
Right.
saying log instead of dog or something.
Right, exactly.
Who gets this? You know, it's a relatively uncommon disease, perhaps because of underdiagnosis. We really don't know how common it is at this point. But who is the age? Is this an elderly disease, a degenerative disease, like we think of dementia? Or
So this is a really good question. It actually presents much earlier than dementia does. The average age is 60, but people are diagnosed with this much earlier, as early as in their 20s, which is very rare. But I've had patients anywhere from early 50s to later 60s with this disease in various stages.
And of course, everybody who's over 60 is going to be terrified at home. What are the normal things you can expect versus signs of early primary progressive aphasia?
I think that's a great question, because I think, for me, probably for many of our viewers, we're like, well, sometimes I forget somebody's name, or I have trouble finding the word for this. How do you know?
I find that's happening more as I get older, or at least I'm more afraid of it as I get older. So, what's the difference?
So even if you watch the segment or any sort of news stations, people who are meant to be fluent in their speech, you'll find a lot of ums and hesitations or fillers for different words. And that's a part of normal speech. We all make errors. We're not completely fluent. Not to panic, and now I'm going to be doing it a lot more. So that's one of the issues that, it's normal. It's part of normal speaking and normal aging. Proper nouns are usually the first to go in normal aging, so let's not be too concerned. When we want to be concerned and reach out to a neurologist or a neuropsychologist, which is who diagnoses the disease along with a speech-language pathologist, is when this is starting to interfere with our activities of daily living, when it's really getting in the way of talking on the phone or working or making plans or reading. We want to follow up and make sure that it's not something more.
Because that's really so typical of so many disorders, which are there's a spectrum of normalcy, and then when it starts to interfere with life, then you begin to say that it's true pathology.
Right. And of course, we want early diagnoses, and you don't want to put something off.
Give me an example of the types of things that I might be saying if I have early disease. What would I sound like? You said proper nouns. Would I think that I want to go to Florida, but I'd say Colorado? What are the things that...
So it depends on the variant, but losing proper nouns and not saying the right name, that's actually part of normal aging. That's not part of a disease like this. A disease like this would really have difficulty in getting your thoughts across. So when you're trying to say something, if I'm telling you that I want to go home, I might instead say, it's time for me to go. I really need to go to where my dog is and where my family is and where I have my bed. My home. But it's going to take me a long time to get there for something that's really common. We call those circumlocutions, trying to find the right word by talking around it. And then, or I might miss a lot of thes and us in my speech, really simplify what I'm trying to say. Exactly what I just did now, groping, trying to find the next word. That might be an early symptom.
It's funny because as you speak, I have 2-year-old grandsons, and some of what you describe is exactly how they are speaking as they are learning to speak. So I'm going to ask you when we come back in the next segment about that, whether this is just sort of going back the way you came. But anyway, it's really interesting the way we develop speech and then the way we lose it. So we'll be back after a short break. Stay tuned.
Don't go away, and we'll be right back.
Hi, Andrea and I are back with Marta Korytkowska. I think I got it right. So I was just comparing my grandchildren to somebody with primary progressive aphasia. Clearly one is learning speech, the other is losing it, but you said you're actually doing research on that. So
part of the research that I'm looking into is comparing the speech of people with agrammatic aphasia post-stroke, so not the primary progressive kind, but aphasia nonetheless, and children, and how their morphemes, those endings, those articles, compare in what they're doing. So there's actually a hypothesis called Jacobson's hypothesis. And
say it again,
Jacobson's hypothesis, and he says that we will lose language in the opposite way that we acquired it. So the last acquired is the first to go. So that may very well be what we're seeing, but that hasn't been substantiated yet in primary progressive aphasia.
Are you finding that the speech patterns are similar in children acquiring speech and those who are losing it when you actually just look at the construction of the sentences that they produce?
Actually, in research, it's been very varied. So in what I've been reading, sort of half have found yes and half have found maybe. So it depends.
To me, that leads to another question about primary progressive aphasia. So how do you go about making a diagnosis? How do you test for this?
So you would see a neuropsychologist and a neurologist who would give you a slew of behavioral testing, a battery of testing, and then they would also most likely conduct imaging via MRI, magnetic resonance imaging, and they would look at the area of the brain that's been linked with atrophy is the anterior region of the left temporal lobe. So again, on the left, where we see post-stroke aphasia and the temporal lobe, across the 3 different types of primary progressive aphasia, with some variations depending on the subtype.
And maybe you could give our viewers just a sample of how does a neurologist or a neuropsychologist, what are some examples of the tests that are done, since, as we were talking in the last segment, it's so fascinating, many tests we might think of are based in language, and so you're trying to sort out what's the language part and what is something else.
Right. So in the 1980s, Marcel Messelum defined this disorder as fluent or non-fluent speech in the absence of a cognitive deficit. So what a neurologist or a neuropsychologist may do is do cognitive testing with visual spatial abilities, ordering different items, memory tasks, again, that don't require language but maybe manipulatives, and then some language testing, and compare the differences of the two along with the imaging.
It's fascinating.
Let me ask lots of questions. Any difference in left-handers or right-handers in developing the disorder? Because we know the speech center can be on the right side, and left-handers, it's about 50% of the time. But also, I've seen this in my own family, that sometimes the speech center is not all that well developed in the brain. So there can be sort of dyslexias of. Do you see any correlation with those and then the later development of primary progressive aphasia?
No, I have not yet, and the research is not there to back that up for primary progressive aphasia yet. There is also some discussion about bilingualism and people who are bilingual developing primary progressive aphasia, and their brain centers are also more sporadic in terms of where language is localized. There's, again, not crazy agreement across studies, but some people have found some differences.
Genetic? Is there a genetic? We'll ask you that 2 ways. Does it run in families at all? And is there a specific gene that's been identified as being correlated with this? Now that we can sequence everybody easily.
So no gene to my knowledge yet. The only thing that I can really compare this to is Alzheimer's disease, because 40% of people with primary progressive aphasia have the amyloid plaques that we find in Alzheimer's disease. So it's not odd that it often gets misdiagnosed, but also those are the biomarkers, and we know that Alzheimer's disease sometimes has a genetic component.
Now, let's talk a little bit about therapy. You're a speech therapist, so you treat this. How do we treat it?
It could be really quite devastating.
It is. It's a life change. So I'll answer sort of both those points in this life change. When somebody's first diagnosed with an aphasia post-stroke, they're not going to get worse. So if you have a stroke and you have aphasia, you're very unlikely to get worse unless there's a second stroke. And you work with a speech pathologist to, 1, get better, and 2, to find compensatory strategies. But when you're diagnosed with primary progressive aphasia, it's progressive. It's going to get worse. So the focus of speech-language pathology services at that point and speech therapy is to educate. We want everybody to know sort of what may happen, what the symptoms are, what's coming, what's next, We want to be able to tell the person who has this disease, but also their caregivers, how best to help them and how best to communicate to get your points across. Language and communication is what makes us innately human. We also want to provide therapy for maintenance. So the goal of therapy is to maintain what we have for as long as we can. And some research has shown that people do relearn items. They can get better for things that they have forgotten, but also we want to maintain. So progress here is not seen as getting better. Progress here is the most important thing is maintaining what you have for as long as you have it. Because inevitably people are going to have to, at some point, maybe leave their jobs and move forward that way.
What techniques do you use to help promote maintenance of language?
Sure. So actually a lot of the information that we have from post-stroke aphasia we applied to primary progressive aphasia because we target the underlying language structure. So if you have a semantic impairment, we reteach you how to use an item. If you have difficulty with the logopenic variant and finding the right words, you might be asked to generate different words to a category or within sentences. And if you're pushed to, you can do 5, we want you to do 7 to that category and keep pushing you forward. Again, describing items, finding the salient features of them so you could talk around them if you need to. And then in the agrammatic variant, a large component is that apraxia, that not being able to produce the sounds, the words, forming the right articulations for each word. So reading has actually been shown to improve production.
Reading out loud.
Reading out loud, structured out loud reading has been shown to improve and maintain the production of multisyllabic words.
Oh, that's really interesting. Now, so I mean, people with aphasias can have varying degrees of difficulty with verbal speech as opposed to written speech and reading speech. So I'm imagining that interventions are very much individualized to what's going on with that particular patient and what works for them.
Of course. So that's actually a multi-part issue because one, we have to individualize to the person with the aphasia themselves. What are their likes, their dislikes, where are they, and what's going to keep them interested in talking? What speech do we need them to produce? Because some research has shown generalization to things that we don't train, and other research has said, you know, if you're training words about animals or about gardening or about cooking, that's the words that people are going to be able to retain, to say, versus they're not going to now be able to talk about transportation because you didn't teach that. And so that's one, what's important to that person. 2 is where are they in the spectrum of the disease? Are they in the beginning or in the middle and the end? Do we work on relearning items that are lost because it's still fairly early? Do we work on maintaining because we're progressing to a certain degree? Or do we work on alternative communication, like pointing to things or using an alternative augmentative communication device like an iPad or a program that will speak for you once you click?
Is written language lost at the same rate as spoken language or reading? Because I know sometimes anatomically with strokes you can maintain the ability to read and understand, but not hear and understand. Do you see the same thing in primary progressive aphasia, or do they all go together?
They seem at this point, again, it's a very early stages, to not go at the same time. Dyslexia tends to develop in some of the variants, as does difficulty with reading. But usually that's as the disease progresses, not in the very initial stages.
We have 90 seconds left, but some of the medicines we use for dementia, Receptive or Amantadine, that's right, yeah. Is that right? Anyway, do they have any effect?
They have been used sometimes in people with primary progressive aphasia as clinical trials because of that Alzheimer's relationship, but they have not shown an effect. So it's mostly behavioral interventions at this point.
And in the last minute, can you talk a little bit about how you might help families who are dealing with this issue as well?
Sure. So teaching families compensatory strategies, so how to talk to their loved one, to simplify their speech, to not interrupt, to have a lot of patience, and to keep planning for the next steps with the neurologist, the primary care physician, the neuropsychologist, and the speech pathologist.
It seems like the late stages of this would be very devastating because it's sort of the locked-in syndrome that we talked about, inability to communicate, yet an ability to understand what's going on around you and to think reasonably clearly. How do patients deal with that?
A lot of people with primary progressive aphasia are then later diagnosed with a depression, or those diseases seem to be correlated to some degree. Maybe correlation is the wrong word to use, but related, because it is a devastating disease. But a lot of people also engage in cooking or gardening or doing things that they liked before.
Well, this is really important information. I think that any family that's dealing with speech problems should probably incorporate this idea, this diagnosis in their consideration. And we got to take a break now, but it's very, very interesting. Thank you. I've learned a lot today.
Absolutely.
When we come back, we'll actually have today's health question. We'll keep Marta on the set.
Right now, let's take a look at some of the upcoming events sponsored by the Western Connecticut Health Network.
This week's viewer question is, can speech therapy help with hoarseness? That's an interesting question. I never thought about that. Marta, you're the expert. Can speech therapy help with hoarseness?
So speech pathologists do see people who have a hoarse vocal quality, but I think we have to go back to the beginning of why do we have a hoarse vocal quality? So was it caused by a prior intubation because of a surgery?
Putting a tube down.
Putting a tube down somebody's throat to help them breathe. Was it caused by chronic vocal abuse or overuse, screaming, shouting? Is it caused by some sort of pathology? So the first thing we want to do in any case is get an ENT consult so we can visualize the vocal cords and see what's happening. And then a speech pathologist might start you on a vocal hygiene program, getting you...
Which means to be quiet, right?
Having good use of your voice, not overusing your voice, not whispering when you're hoarse, because you're actually causing more damage sometimes, depending on why you have this issue. Drinking a lot of water, reducing your caffeine intake, and then working with you on some strategies from there.
So, but as a speech pathologist, what would you do? Somebody says, I always sound hoarse.
I would say get an ENT consult first.
So you want to make a diagnosis about what's going on,
Right.
and then you can tailor therapy to that particular individual and problem.
Right, and we want to look at everybody's background and so forth as well, smoking history, caffeine intake.
Right, there are a whole host of causes for hoarseness. I think of polyps on the vocal cords from people who are smoking. I know people with lung cancer on the left side can actually hit the nerve that goes to the vocal cord. So
you get a viral vocal cord paralysis. So.
Right, so we don't want to treat something without knowing why it's happening.
Absolutely.
So all these wonderful things that you can treat. But thank you very much.
Thank you so much for answering the question
really interesting stuff today.
Thank you for having me.
These brain diseases, we're just at the threshold of being able to understand them. There's so much for us to learn. So if you have a question at home what you'd like to ask on Health Talk, please contact Andrea and me at healthtalk@oralhealth.org.
We'd very much like to thank our guest, Marta Korytkowska, today. She's a speech pathologist. Thank you so much for coming on Health Talk, for giving us so much good information.
So we'll see you next week on Health Talk.
Be well.